Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject, pediatric surgery made easy. This is anorectal malformations in children. It's very important subject for all pediatric surgeon and pediatrician dealing with the children and neonates. Let's start. Anorectal malformations. Our objective will be related to understand the anatomy and the terminology of anorectal malformations, the old and the new classification for anorectal malformations, the male defects and the female defect. Also, we will speak about the functional outcome after the surgery and repair for this disorder. And finally, we will speak about some complications related to the surgical repair. Anorectal malformation is a relatively common congenital anomaly, affecting about 1 in every 4,000 to 5,000 newborn, and it is slightly more common in the males. Anorectal malformations have a wide spectrum, ranging from a relatively simple malformation with a good functional prognosis for urine and control and bowel control to complex malformation with a poor functional prognosis related to the urinary and the bowel control. In males, the most common type of the defect is anorectal atresia with rectourethral fistula. In female, the most common type is rectovestibular fistula. Cloaca was misdiagnosed early as a type of rectovaginal fistula. However, this was corrected that many cases of rectovaginal fistula is actually a cloacal malformation. Previously, as a result of this wrong diagnosis, the repair was done for the rectal component only, leaving the patient with what's called persistent urogenital sinus. And we will explain this later. The classification of anorectal malformation. Previously, there is an old classification. Classify anorectal malformation as low, high, and intermediate. Actually, this classification is not used today because it's very misleading classification, like classifying people as a tall and short. What is the importance of this classification? Number two, this classification not giving any idea about the specific anatomical type of anorectal malformation. Number three, no idea about a specific surgical plan, whether to open the child posterior sagittal or this case will need an abdominal or laparoscopic approach. Also, this classification gives no idea about the prognosis of the child regarding the urinary and the bowel control. So the old classification not used nowadays. The new classification is very important for all pediatric surgeons. It is a therapeutic and prognostic-oriented classification, classifying the anorectal malformation into, according to male defects or male anomaly and female anomaly. On the male anomaly, we have rectopreneal fistula, the rectum open in the perineal, and we will describe it in details. Rectourethral fistula with 3 subtypes: rectopulbar fistula, rectoprostatic fistula, and rectobladder neck fistula. The third type is imperfect anus without any fistula, and the fourth one is rectal atresia or rectal stenosis. On the other hand, regarding the female anomaly, there will be rectopreneal fistula like that in the male, rectovestibular fistula, the rectum open with a small fistula in the vestibule of the vagina, and we'll describe it, and what's called cloacal malformation, or a spectrum of anomalies related what's called cloaca, in which the whole the urinary bladder and the vagina and the rectum open in one single common chamber, and maybe also imperforate anus without fistula and rectal atresia or rectal stenosis. At first, we will speak about the male anorectal malformation. Number one, or the first defect in the new classification, is the rectoperineal fistula. As you see, this is the rectum and this is the urethra. The rectum normally open within the muscle complex here. And in this anomaly, it is displaced. And this is the lowest type of the defect, may be called covered anus, anal membrane, anteriorly mislocated anus, or bucket handle malformation. The rectum located within the most of the sphincteric mechanism. As we see, this is the sphincteric mechanism, except for the lowest part, which is anteriorly mislocated. Sometimes the patient present with this median raphe with secretions of meconium on the perineum or white mucus. This is the first type, rectoperineal fistula. Anorectal atresia with rectoperineal fistula. The second one is the rectourethral fistula. In these cases, the lower end of the rectum open or join the urinary tract, specifically the urethra. Maybe lower urethra or bulbar urethra, maybe higher or prostatic urethra. So this is the second type of the male anomaly. The third one is rectobladder neck fistula. About 10% of the cases, the rectum will open by fistula at the bladder neck. What is the bladder neck? Near the junction between the urethra and the urinary bladder. So the rectum here open high at the bladder neck. So urethral fistula may be low or bulbar, prostatic fistula, or rectobladder neck fistula. The third type will be anorectal atresia without fistula. There is atresia or obstruction of the rectum, however, no fistula. The rectum ends blindly, about 2 cm from the perineal skin. The rectum and urethra separated only by the thin common wall. Patient will have a well-developed sacrum and a good muscle with good prognosis for the bowel control. Half of the patient with this type of anomaly, with anorectal atresia without fistula, will have a Down syndrome. And more than 90% of the Down syndrome patients have this defect, suggesting that there is maybe a chromosomal link linking the Down with anorectal atresia without fistula. The last one is rectal atresia or rectal stenosis. Less than 1%, the rectal lumen is totally atretic or partially stenotic or interrupted, leaving 2 pouches. Upper pouch is a dilated rectum, and the lower one is a small anal canal that is separated by a thin membrane or dense fibrous tissue. And these patients usually have an excellent functional prognosis regarding the urinary and bowel control. Now we must speak about the associated anomalies. It's very important when you see a case of anorectal malformation, whether rectoperineal, rectourethral, with H3 types, or anal stenosis or atresia, you must search for associated anomalies. Most of these babies may have cardiovascular anomalies, gastrointestinal anomalies, sacral and spinal cord anomalies, genitourinary and gynecological anomalies. So your role as a pediatric surgeon is to exclude or rule out the presence of these anomalies during the first 24 hours of the baby life. The cardiovascular may be present in the form of atrial septal defect, patent ductus arteriosus, ventricular septal defect with Fallot disease. Some patients are compensated and others may be uncompensated. Gastrointestinal anomalies. There may be an esophageal atresia, duodenal atresia. Regarding Hirschsprung disease, there was a recent report reporting 3 cases out of 2,100. And the overdiagnosis of this association probably may be due to the high incidence of constipation seen in the patient with anorectal malformation. And we will explain this point later. Sacral anomalies. Most frequent associated defect, there may be missed one or more sacral vertebrae. The sacrum is the lowest part of the vertebral column. Hemisacrum, usually associated with presacral mass and poor bowel control. Also, spinal hemivertebrae can have a negative implications on the bowel and the urinary control. The valuable objective measures for the caudal regression syndrome. So it is very important for the pediatric surgeon to study the characteristic of the baby sacrum when the child have an anorectal malformation. There is what's called sacral ratio. What is sacral ratio? It evaluates the degree of the sacral development and correlate with a bowel and urinary function. It measures the length of the sacrum in relation to fixed point. So children with anorectal malformation may have a varying degree of the poor sacral development. The normal sacral ratio is 0.7. If the ratio is more than 0.7, associated with good bowel control. If the ratio is less than 0.4, associated with poor bowel function. How to measure the rectal ratio? It's very important for all pediatric surgeons to be familiar with this radiologically. It measures radiologically. We take 3 points, A and B and C. The first one, or the first line, will join the uppermost point of both iliac crest. This is A line. And the B line will join the lowermost point of the sacroiliac joint. And the third one will be parallel to the 2 above lines and touch the lowest radiologically visible point or the tip of the coccyx. So you must have these 3 lines on the plane radiograph, 1, 2, 3. And then you divide the distance between the B line and the C line over the distance between A and B. If it is 0.7, it's normal. If it is like more than 0.7, good bowel control, less than 0.4, associated with poor bowel function. So this is very important to assess the characteristic of the baby sacrum during the first 24 hours of life. Moreover, there is maybe spinal cord anomalies. The most important one is what's called tethered cord, with more influence on the urinary and the motor activity of the lower limb. The diagnosis with the lumbosacral ultrasound can be done during the first 3 months of life. So you don't need more than simple ultrasound to search for the tethered cord in the first 3 months of life. After that, the diagnosis will need an MRI of the spine. The operation to release the tethered cord will improve the urinary function and avoid motor or sensory deterioration of the lower limb. So it's mandatory to search for the presence of the sacral anomalies or spinal cord anomalies in any baby with anorectal malformations. From these data, we can conclude that we may have a continence index or suspicion. The continence potential can be predicted from, number 1, the type of the anomaly. Rectoperineal, rectourethral, rectoprostatic, rectobladder or atresia without fistula. Number 2, the quality of the sacrum and the quality of the spine can predict that the baby will have a control or not. So with lower anorectal malformation, with normal ratio, sacral ratio and normal spine, the baby will have an excellent prognosis for a bowel control. On the other hand, with high anorectal malformation, poor sacral development and spine, the prognosis may be poor for both bowel and urinary control. It's very important to understand this continent index, as the parent of the baby will be waiting you and asking about if there is baby available to control urine, to control stool, litter or not. So continence index is very important. Other anomalies may be genitourinary anomalies, higher malformations, and cloaca or rectobladder neck have about 90% risk of genitourinary anomalies. However, the lower defects have a less than 10%. There may be hydronephrosis, urinary tract infections, and may end with metabolic acidosis and poor renal function. So ultrasound on the abdomen and the kidney is very important during first 24 hours to diagnose associated genitourinary anomalies. Very important to perform the ultrasound as a simplest investigation. The gynecological anomalies, yes, may be significant concern in the patient with anorectal malformation. The abdominal gynecological organs must be inspected and its patency will be tested at the time of the definitive repair or colostomy closure. There is maybe hydrocolbus with urinary obstructions or maybe Mullerian anomalies, maybe duplicated vagina, duplicated uteri, and this will need an intervention at certain age when menstruation start to occur. Now we will speak about the newborn management. It's very important for you as a pediatric surgeon to manage newborn with anorectal malformation. There are 4 important questions that must be answered during the first 24 hours of life. Number 1, what are the type of the anorectal malformation present according to the new classification? Number 2, what associated anomalies? Number 3, what is the characteristic of the baby's sacrum? Number 2, what is the operation required for this baby? Is it primary posterior sagittal anorectoplasty, or what's called PASAR, or opening a colostomy and delay the definitive repair for few months? The role of the pediatric surgeon is to answer these 4 questions when you face any baby with anorectal malformations. At birth, number 1, careful prenatal inspection is very important, and also checking the urine for meconium. Number 2, no decision about to perform colostomy or primary surgery before the 24 hours of life, as significant intraluminal pressure is required for the meconium to be forced through the perineal fistula. You need increased intra-abdominal pressure to push the meconium to go through the fistula. So you cannot take a decision early. Otherwise, you will take a wrong decision to perform colostomy or to perform anoplasty. Number 3, no radiological evaluation before 24 hours, as the rectum is usually collapsed by the pelvic sphincters, and this early imaging may show very high rectum with misdiagnosis. So please, very careful that you will need a careful and thorough perineal inspection, no decision in the early before 24 hours, no radiology before 24 hours. During the first 24 hours, you will use this time to, number 1, support the baby, number 2, search for associated anomalies. So you will give an intravenous fluids, antibiotics, nasogastric decompressions, evaluate for associated anomalies, cardiac, esophageal atresia, duodenal atresia. You will study the characteristic of the baby's sacrum, spinal anomalies, tethered cord. You will measure the sacral ratio. You will perform renal and abdominal ultrasound, and you will evaluate for any associated anomalies and give support for your baby, because you cannot take a decision for surgery and you cannot perform radiology regarding the level of the anomaly during these first 24 hours. After 24 hours, you will perform re-evaluation of the perineum. for the presence of the meconium, perineal fistula. Also, you will re-evaluate the urine for the meconium. You may have many options. Number one, if you, after 24 hours, you find that the baby has a meconium on the perineum or perineal fistula, you can perform BASARB, posterior sagittal anorectoplasty, without protective colostomy in the newborn period, or may be delayed for a few months with dilatation of the fistula. To perform a primary BASARB, this will depend on the experience of the surgeon. If the surgeon is very expert to deal with this neonate or this newborn with a meticulous and fine handling and dissection or not, and will depends on also on the condition of your baby. If there is associated anomalies, is your baby in a good condition and good health, no associated anomalies. So according to the type of the anomaly, if you find meconium on the perineum or perineal fistula, the reasonable option is to perform BASARB without protective colostomy. However, if you find perineal fistula and the baby is ill, there is associated anomalies, the surgeon experience not allowing to perform BASARB as a single stage in this age, you may perform a colostomy and delay the repair. You may dilate the fistula and wait for few months, according to the situation. Number two, if there is a meconium in the urine or diagnosing of the rectourinary fistula or abnormal sacrum or flat perineum, the colostomy will be the reasonable one to perform colostomy and wait for the definitive repair. And from this colostomy, you can perform colostogram and diagnose the distal rectal anatomy and fistula. This information is very informative and very important for all pediatric surgeons and dealing with children or neonates with anorectal malformation. The third situation, if no meconium seen on the perineum or the urine after 24 hours, you wait for 24 hours to re-evaluate. You may find meconium, perineal fistula. You may find meconium in the urine, rectourinary fistula, or the third situation, if no meconium seen on the perineum or in the urine. In such cases, cross-table lateral radiograph is performed to locate the distal rectum. Where is the distal rectum? As we see, the patient is placed on the bone and the pelvis elevated to show the air in the distal rectum. If the rectal air is visible distal to the coccyx and no significant associated defect, in such case, we can perform BASARB without colostomy as a single stage. Again, if there is associated defects, if the condition of the baby is very low, you may change this solution. Also, if the rectal air doesn't extend beyond the coccyx, the colostomy will be indicated, and it will allow for the later assessment or definement of the rectal anatomy, where is the distal rectum and where is the fistula regarding the urinary system. So this cross-table lateral radiograph. Previously or historically, we perform what's called invertogram. We invert the baby and put a mark and show the heights of the bowel or the air according to this previous imaging. However, today we perform what's called cross-table lateral radiograph. On the prone position, elevate the pelvis, and we will see the skin to the bowel distance or the heights of the rectal air. This radiology not performed except after 24 hours to allow for the rectum to be distended with the gas. As early imaging, the rectum will be collapsed and there is misleading diagnosis. Performing the definitive repair of the anorectal malformation should not be delayed more than 2 to 3 months of age, and this has an important advantage. Less time with abdominal stoma, not to leave your child or your baby with abdominal stoma for more than that time. Less size discrepancy between the proximal and the distal bowel at the time of the colostomy closure. If you leave the bowel, leave the child for a long time, you will find discrepancy, large bowel proximal and very small bowel distal, so the anastomosis will be difficult. Also, anal dilatation will be easy. Also, there is a potential to improve the acquired local sensation by placing the rectum in the right location early in life. So if you place the rectum in the right location early in life, even from the theoretical point, it seems to improve the local sensation. Some surgeons prefer, or some surgeons tries the options of performing repair of all anorectal malformations during the neonatal period without performing colostomy. To avoid their argument, to avoid the morbidity related to the colostomy opening and closure. However, there are two important points. Number one, if we perform early repair in the neonatal period without colostomy, the distal colostogram is not performed, which is very helpful to define the distal rectal anatomy and rectourinary fistula. Number two, the pediatric surgeon will look blindly for the rectum during BASAR. If he elected to perform an early BASAR without colostomy, will look blindly, and this may result in a serious complications like injury of the urethra, damage of the bladder neck, injury to the ureters, division of the vas or seminal vesicles. So this school of performing early repair in the neonatal periods of all anorectal malformations without colostomy need an expert surgeon, have two problems or two drawbacks, or that distal colostogram will not be performed. The pediatric surgeon will perform blind exploration of the perineum, searching for the rectum without any colostogram or any dye study that will be helpful to locate where is the rectum. This is an algorithm for the management of the male newborn with anorectal malformations. It's very important to follow this algorithm. No anus birth, re-evaluations after 24 hours. During these 24 hours, you will perform urine analysis, kidney ultrasound, sacral X-ray, and spinal ultrasound, nasogastric tube insertion for esophageal atresia, echo for cardiac anomalies. And after 24 hours, you may find one meconium on the perineum or the perineal fistula. In such case, you can perform direct anoplasty with or fistula dilatation according to the experience of the surgeon, according to the condition or situation of the baby, associated anomalies. Number two, meconium in the urine after 24 hours or abnormal defects, abnormal sacrum flat perineum. In such case, a colostomy is indicated. Number three, no meconium on the perineum or in the urine after 24 hours, which is called undefined malformations. In about 5 to 10% of the cases, in such case, the cross-table lateral prone X-ray is indicated to show rectal gas above the coccyx or rectal gas below the coccyx. And to determine if there is high rectal gas above the coccyx, you will perform colostomy with distal colostogram and show if the rectum is reachable through BASAR, you will perform BASAR. If rectum is not reachable through BASAR, you will perform laparoscopic assisted or perform abdominal approach. If the rectal gas below the coccyx, you can perform BASAR with or without colostomy, depending on the situations of your child or your newborn. Don't forget the follow-up at 6 years, at 6 months, 1 year, and annually, and also the continence assessment at the 4 year. So this is very important clinical algorithm for the management of the male newborn with anorectal malformation. Don't perform early rush to colostomy or to perform primary BASAR. Don't perform early rush to perform cross-table X-ray, as the result in the early 24 hours may be misleading and will lead to wrong intervention. The principles of the surgical repairs. You must know the goals of the surgery for anorectal malformation. Number one, we need to separate the rectum from the urinary tract and close the urethral fistula. Number two, We need to pull down the rectum and place it precisely within the sphincteric mechanism. We may have one or two surgery. One surgery, one single stage BASARP, or two colostomy followed by the BASARP, then closure of the fistula. Surgeon experience is very important. Type of the anorectal malformation, associated defects, baby general condition. All these factors contribute to the pediatric surgeon decision to choose primary or delayed surgery. The colostomy. Colostomy is very important in the cases of anorectal malformations when the diversion is indicated or needed. It's very important after colostomy to perform what's called high pressure distal colostogram, which is a key diagnostic study to determine the distal rectal anatomy and the urinary fistula. Also, mechanical cleaning of the distal colon is very important at the time of the colostomy. How to perform technically correct colostomy? Number one, we need in anorectal malformations, we need completely diverting colostomy with separating both stoma. It's not allowed to the content or the stool from the proximal stoma to pass to the distal stoma. Otherwise, there will be urinary tract infections, there will be contamination, maybe sepsis. So we need completely diverting colostomy, like this. We completely isolate the proximal from the distal part of the colon. We need completely isolating both stomas. Number two, it's very important to leave enough distal bowel. This part must be enough to allow for distal pull-through. This part will be pulled and grasped to overcome the gap and perform the new anus. So if you perform your colostomy very low, you don't leave enough redundant bowel. That's really very important. Number three, the best or ideal position to make the colostomy in the cases of anorectal malformation is in the descending or the upper sigmoid, which is very important at this point. That sigmoid comes out of the left retroperitoneum, so there is some point of fixation to avoid colostomy prolapse. So for important items, when you decide or take the decision or go for colostomy in anorectal malformation, completely diverting, separating both stomas, leaving enough distal bowel to allow for subsequent pull-through, making the colostomy in the descending colon, lower descending or upper sigmoid is ideal in these cases. Please don't perform transverse colostomy, because in these cases, in the babies with large rectourethral fistula, the urine will pass into the colon and remain in the colon and absorbed, may lead to metabolic acidosis with deterioration of renal function. Number two, don't perform loop colostomy. We mean by the loop, we hang one loop of the colon, leaving the two parts of the colostomy connected by the posterior wall. So the stool can pass from the proximal colon to the distal and lead to urinary tract infection, distal rectal pouch dilatation, fecal impaction, and this may cause severe constipation later in life. So we decide to perform a descending colon colostomy, completely diverting, separating both stomas, leaving enough redundant bowel to perform an ideally and correctly colostomy for anorectal malformations. This is about the high pressure distal colostogram. We name it high pressure. Why? Because we need to exert some pressure during injection of the dye. So this pressure can overcome the contractions of the pelvic structures. So we put, this is a balloon of the catheter to occlude the stoma to prevent the retrograde flow of the dye. Then we inject the dye into the distal colon or distal rectum. And after that, we exert some hand-controlled pressure. This hand-controlled pressure will allow the dye to be forced through the fistula. This is a urinary bladder, and will define the rectal anatomy and fistula. So it's very important to perform high-pressure distal colostogram. After performing the colostomy, before the surgical repair to define exactly the positions of the distal rectum and the fistula to avoid the potential damage during surgery to the bladder, neck, urethra, and the seminal vesicle. This image is very important. This is high pressure distal claustrogram demonstrating that there is rectopalpar urethral fistula. As we see, this is the fistula and there is a filling of the urinary bladder. This is an example or demonstrations of what's called Horner's elbow. Well demonstrate, you can imagine the levels of the rectourethral fistula. The rectourethral fistula may be here at the elbow or what's called rectobulbar fistula in the lower part of the urethra. Maybe here at the triceps or called rectoprostatic fistula, and maybe here at the shoulder or rectobladder neck fistula. So you can imagine that this Horner's elbow will demonstrate the levels of the rectourethral fistula. You may have a newborn with rectobulbar fistula, rectobulbar, rectoprostatic, and rectobladder neck fistula. This idea will be given after performing high-pressure distal colostogram. Now we will speak about some principles of the repair regarding some types of anorectal malformations in male newborn. Rectobulbar fistula, we place the child prone with the pelvis elevated. Electric stimulator is used to determine the exact position of the muscle sphincters, and the length of the incisions varies starting from the tip of the coccyx and ending at the perineal orifice. The perineal fistula sometimes require minimal basar, and the higher defect may require full basar. As we see, the basar incision will divide what's called the parasagittal fibers. There is fibers here on both sides of the midline and part of the muscle complex called parasagittal fibers. And these parasagittal fibers, there is also some other fibers surrounding the rectum called the muscle complex. This is a muscle complex. And there is also the levator muscle. So we may have three structures very important regarding the anorectal anatomy. The pediatric surgeon must know them very well. Number one, the parasagittal fibers. Fibers parallel on each side of the buttocks, left and right. And there is what's called muscle complex. Muscle complex is a longitudinal fibers like this surrounding the rectum and reaching down to the levator muscles and the levator muscle. Three important muscles. The basar incision must divide this muscle complex exactly in the midline, leaving enough muscles on the right, enough muscles on the left. So it's very important to perform this incision exactly midline. Sometimes dissecting the coccyx will help to gain an exposures in the upper part of the wound with a diathermy. This is the coccyx. Dissections on either sides of the coccyx may be helpful. After the entire sphincteric mechanism divided exactly in the midline, leaving equal muscles on the both sides, regarding the parasagittal and the muscle complex and the levator, you will find these white tissue structures in the midline, which is usually the rectum. And its characteristic white tissue structure is very known to all pediatric surgeons. At this point, the importance of the good distal colostogram is very helpful to determine where the rectum ends, in the rectobulbar, in the rectoprostatic, or high or low rectoprostatic. Then we perform attraction sutures as we see on the rectal structures. This is after that we will incise the rectum to search for the fistula. Once the fistula visualized, we can take some silk sutures around its orifice. The very important and very meticulous will the patient put in the prone position. So the wall of the rectum you see is the posterior rectal wall. So after you see the posterior rectal wall, there will be in the downside is the anterior rectal wall. This anterior rectal wall is fused with the urethra, and there is no plane of dissection. From the urethra, you must perform a plane of dissection for these intimately closed two walls. Multiple traction sutures are put in the rectal mucosa, and the rectal mucosa is dissected. We can see this image. This is the rectum opened, and this is the fistula, the small one. Here the problem is that the anterior rectal wall is forming one wall or intimately close to the urethra. So if the surgeon is not very careful, can injure the urethra at this side. So how to avoid? This is the same operative photo. We perform just mucosal stay sutures in a semicircle just above the fistula and trying to dissect submucosal to elevate the fistula, aiding with the lateral dissections of the rectum to help to define an areolar plane or thumb plane to go up and dissect the fistula. Very difficult part of the procedure. The white fascia on the lateral side of the rectum is identified and dissected as close to the rectal wall. This will help the anterior dissection to be completed. So it's very important to form or to dissect these two intimately closed walls, very meticulous. The anterior rectal wall must be adequately dissected free of the urethra, so not to leave any remnant of the fistula. As we see, this is the fistula and this is the anterior rectal wall, and here is the plane of dissection. It's very difficult and very essential step. Not to leave any remnant of the fistula, sometimes called roof or remnant of the original fistula. The full separation is relies on the surgeons that find typical areolar plane between them. Very difficult and very meticulous step. The extent of the dissection don't explain the rectal dysmotility in some patients with higher defects, as patients with lower defect may have some more constipations. There's maybe inherited motility disorders more prevalent on the lower defect. After the fistula closures, we determine the limits of the sphincteric anterior and posterior to put the rectum in the proper site. The rectum must be positioned in front of the levator muscles. We mean that the levator close behind the rectum, and the limit of the complex exactly determined, and then we perform anoplasty. We can see here the rectum is after dissection, the levator, this is suturing the levator, and the rectum will be grasped below the levator, and the levator will be sutured in front of the rectum. As we see, this is the levator muscle, left and right part, and this is the rectum. After that, we can anchor the posterior edge of the sphincter to the rectum to prevent rectal prolapse. Very important for all pediatric surgeons to put the rectum in the proper positions and suturing the levator in front of it. If we face a case of rectoprostatic fistula, we mean that the rectum open in the prostatic urethra as a higher point. The initial search of the rectum should be just under the coccyx. We may have two types, prostatic fistula with narrow distal rectum, and the rectum will be very difficult to identify through BASARP and need laparoscopy or laparotomy, and the prostatic fistula with bulged distal rectum. And this can be approached through the BASARP. So prostatic fistula means that the rectum ends in the prostatic urethra. Maybe two types, high prostatic urethra or high prostatic fistula and low. The low one can be approached from the posterior sagittal anorectoplasty. The high one will lead to perform assisted laparoscopy or laparotomy to separate the rectum from the urethra using intra-abdominal approach in high cases. The perirectal dissections is longer in such cases of the rectoprostatic fistula, and the laparoscopy will be very helpful. At the end of the dissections, the rectum will remain perfused because the rectum will depend on the intramural blood supply from the inferior mesenteric artery. The other varieties is the rectobladder neck fistula. Rectobladder neck fistula, this means that the rectum joins at the bladder neck, very high. And in such cases, the BASARP will be not appropriate to reach the fistula because the rectum open in the bladder neck high in the abdomen. And in such cases, we need laparoscopy or laparotomy. As we see, this is laparoscopic view. The rectum enter in the bladder neck. in a T-shaped manner. This is the longitudinal and this is the T-shaped. Usually there is no shared common wall. The very important laparoscopic landmark is that we dissect the rectum starting from the peritoneal reflection and go down. If a 3 millimeter Maryland can completely cross the distal rectal fistula, here the fistula can be ligated and divided. So this is landmark for the laparoscopic surgeon when performing a laparoscopy for anorectal malformations or rectobladder neck fistula, when or where you will ligate the fistula when your instrument, Maryland 3 millimeter, can completely cross the fistula or the distal rectum. This is most probably the end of the rectum, and the rectum will go to enter or join the bladder. Very important that dissection performed close to the rectal wall and that inferior mesenteric artery is preserved. This is the inferior mesenteric and this is the marginal vessels connecting to supply the colon. What's the problem? During creation of the colostomy, for example, here the colostomy will be performed here, these marginal vessels may be ligated. So during dissection of the distal rectum in the Bell's row, if you divide the inferior mesenteric very high, you will perform ischemia of the lower part of the colon as these branches or arcades is destroyed during colostomy creation. So what's well known to all of us that there is a marginal artery supplying the whole colon and rectum, so you can ligate the inferior mesenteric at its origin and pull through the colon. This information needs to be modified regarding the anorectal malformation. As during anorectal malformation, colostomy may be performed, and this colostomy will ligate some of this communication and disrupt these marginal vessels. So if you decide to pull through the distal rectum, you must preserve the inferior mesenteric artery to guarantee that there is an adequate blood supply to supply the distal bowel. Once the rectum mobilized, the baby legs will be lifted out and the small mid-sagittal incisions and grasping with a clamp will be performed to put the rectum in the perineum exactly within the sphincteric mechanism. Distal rectum pulled through to be situated in the center of the sphincteric mechanism, and the tractions from below can demonstrate if there is any points of the traction to be divided by the laparoscopy. Regarding the imperforate anus without fistula, so we speak about the rectobulbar fistula, the rectoprostatic and rectobladder neck. In the rectobulbar, we perform primary Bassab and we speak about some principles, not all details, but the operations needing separate session to be discussed. Also regarding the rectobladder neck fistula and the high and the low rectoprostatic fistula. Now we speak about the imperforate anus without fistula, type of anorectal malformation. The blind end of the rectum usually located at the level of the bulbar urethra and there is no fistula. However, the rectum needs to be carefully separated from the urethra as these two structures have a common wall, even if there is no fistula. Rectal atresia and stenosis also approach it through Bassar. Upper rectal pouch is opened and the distal anal canal is split and there is an end-to-end anastomosis. If there is a presacral mass identified, we must exclude its connection to the dura, and on many cases it can be removed on the perisacral dissection in conjugation with the neurosurgery assistance at the same time of the rectal repair. So these cases of the rectal atresia or rectal stenosis may be associated with this pre-sacral mass and may need neurosurgical consultation. So this is the first part of our presentation regarding the male anorectal malformation and its principle of management. Now we will shift to the other hand, which is the female anorectal malformation. Female anorectal malformations may be rectoperineal fistula, maybe rectovestibular fistula, and maybe cloacal malformations or spectrum of cloacal anomalies. Rectoperineal fistula, we mean that the rectum position within the most of the sphincteric mechanism, except the lower part anteriorly mislocated like in the male defect. The rectum and the vagina are well separated. The key issue is the opening or the location of the anal opening in relation to the sphincteric mechanism and the length of the perineal body. So this is the first and the simplest type. The number two is the rectovestibular fistula. Common defect in the female with excellent functional prognosis. There is will be normal urethral meatus and normal vaginal opening. However, there is a third opening in the vestibule. This is rectovestibular. This is the vestibule. About 5% of the patient may have two hemivaginas with vaginal septum. So this is a rectovestibular fistula. Now we will shift to what's called cloacal malformations. What's it mean? It's very complex malformation, have a wide spectrum of anomalies, in which the distal part of the rectum, the distal part of the vagina, and the distal part of the urinary bladder fuse and form single common chamber. All the three parts will fuse together, forming single room or single chamber. The lower rectum, the lower vagina, and the lower urinary bladder. The female born with anorectal atresia, a small-looking genitalia, and single perineal orifice. There will be no three orifice as usual. Normally, the female perineum contains three orifices: the rectum, the vagina, the urethra. This is normal three orifice. In such cases of the cloacal malformation, the baby will born with single orifice. These single orifice include the rectum, the vagina, and the urinary bladder. All three fuse together and open with externally on the perineum with this single orifice. It is a challenging job for the pediatric surgeon to separate these three structures and create the normal three opening. As we see in this image, this is rectum and the vagina and the bladder, and all three ending with what's called common channel. This common channel may be ranged from 1 to 8 cm in length, and this length has a very important significance to what we call the spectrum of the cloacal anomalies. So we may have a short length or short common channel. This part is very short, and we may have a long one indicating that the rectum, vagina, and urinary bladder is very high and sending long tube to the perineum. So in the most benign side of the spectrum, we may see patient female with common channel less than 3 cm. This is the common channel here, and this is the opening on the perineum. These babies will have a well-developed sacrum, normal appearing perineum, and adequate muscle and nerve, good functional prognosis regarding the bowel and the urinary. The patient can be repaired with BASAR for dealing with the rectum and what's called total urogenital mobilization. What's urogenital sinus mobilization? The fusing urinary bladder and the vagina is called urogenital. Urinary bladder and genital the vagina. Urogenital sinus. So the operation will be urogenital sinus mobilization to move this urogenital sinus. And the BASAR will dealing with the rectum. So the first step is to separate the rectum by the BASAR and then perform moving these two parts as a single unit, moving this sinus, urogenital sinus mobilization. This will be applicable only if there is a short common channel. This common channel is very short, so there is no long distance between these structures and the perineum. So we can pull them down or perform urogenital sinus mobilization to the perineum after performing BASAR before the rectum. In the most severe side of the spectrum, we may find patient with common channel 3 cm more, maybe 5, maybe 6 cm, up to 8. This is more complex and challenging for the pediatric surgeon. As we see, this is a common channel, very long. Vaginal mobilization is often difficult. The vagina will be very high in the abdomen, and you need to pull this vagina to the perineum. So the mobilization is very difficult. The vagina may need to be separated from the common channel, and also vagina may need to be augmented or replaced. So the problem here is that the common channels, this organ will be high up in the abdomen. So the pediatric surgeon need to travel a long distance to reach the perineum and performing the 3 usual normal opening of the rectum and the vagina and the urinary urethra. Also, Mullerian structures are very common with this type, as a duplicated vagina, duplicated uteri may be present, or vaginal septation. There is maybe septum, and we may have double vagina. Sometimes these 2 hemivaginas are very high in the abdomen, and we are not able to bring them down. The more common and the more sequelae is this high vagina may become distended with the urine and vaginal mucus from the fistula or the common channel, become distended and reaching huge size and compressing the trigone of the bladder, compressing the ureters, interfering with the drainage of the urinary system, lead to hydronephrosis. So the most severe side of the spectrum related to the length of the common channels may present with a female child with more complication. If you see a female child with a long common channel presenting, you must exclude the presence of the hydrocolpus or biocolpus, the presence of the hydronephrosis by performing ultrasound. It's very essential for the pediatric surgeon. So the newborn management of the female anorectal malformation, where it starts as in male perineal inspection at birth. You may see very clearly perineal fistula or vestibular fistula, and you are very lucky to find perineal fistula or vestibular fistula, clear or simple anomaly. Or on the other spectrum, you may find single perineal orifice, what's called cloaca, with a high risk of associated urological defects, and you need to perform complete urological evaluation, abdominal and pelvic ultrasound, to look for the hydronephrosis and the hydrocolpus or biocolpus. So, like in male, the first 24 hours should be used to evaluate for associated anomalies. After 24 hours, we perform, as in a male, re-evaluation of the perineum. To confirm the presence of the perineal fistula, we can perform primary repair without colostomy, primary BASAR to move the perineal fistula. However, depends on the surgeon experience, depending on the condition of the baby, associated anomalies. If you find a vestibular fistula, means that the rectum open the vestibule of the vagina. In such cases, which is the most common female anomaly, primary repair can be performed without colostomy. However, these children or females need a perioperative bowel preparation, good preparation, post-operative feed with only clear fluid and no solid stool. This type is very simple and straight type. However, we have many complications of these types regarding that many cases performed incorrectly. There is maybe no surgeon experience to put this vestibular fistula actually within the sphincteric complex. We may have many surgeons with infection after repair of the vestibular and the recurrent cases. We may see recurrent cases. So this is the most benign type and the present with most complications, which is normally must be not present. You deal with a very simple anomaly. Occasionally, the infant with the perineal or vestibular fistula may have a significant associated anomalies. or unstable related to cardiac anomalies, related to other anomalies than anorectal. In such conditions, the surgeon may have to choose between dilatation of the fistula to facilitate the emptying of the colon, performing the colostomy, and delay the definitive repair in few months. So the first two options to perform primary repair without colostomy depends that the baby don't have a significant associated anomaly and need the baby in a stable condition. So please put these two items in a balance. We're not dealing with anorectal malformation alone. We are dealing with a patient. We are dealing with a baby. So if the conditions of the anorectal require primary repair and the baby unstable associated anomalies, we shift to perform staged repair. This is more safe for the baby life. If the perineal inspections after the 24-hour disclose that there is a single perineal orifice, cloaca, this is required colostomy from the start. The hydrocolpus drainage, if present, must be searched for. And if the patient have two hemivaginas, these two hemivaginas may have double hydrocolpus required to drain the both chambers of the vagina. Also, endoscopic examination is very important. And in rare cases, we need to perform vesicostomy, opening a small opening on the urinary bladder on the suprapubic area if the common channels is very narrow and doesn't drain the bladder, and this is rarely performed. If there is no visible fistula, you perform perineal inspection at birth, wait for a 24-hour, and then perform re-evaluation, and you surprisingly don't find any fistula or no evidence of meconium, and this happens in less than 5% of girls. This requires the cross-table radiograph, as in male anomaly. If the rectal area is very close to the skin and there is no visible fistula, this baby may have whether narrow perineal fistula or no fistula at all. In such cases, if the baby is stable, you can perform primary operation without colostomy. However, most of the infant without the fistula have a Down syndrome. So if the associated conditions of the Down make the rectal repair not visible in the newborn period, the colostomy will be a wise decision, and it will be followed by the definitive repair later. So the re-evaluation of the perineum in the female may show perineal fistula. You will go to the primary surgery if the baby conditions allowed to do this. Number two, vestibular fistula, also primary repair if the condition is okay. Number three, single orifice or cloacal malformations. In such cases, you require colostomy, drainage of the hydrocolpus, assess for the hydronephrosis, and perform endoscopic examination. The fourth option, no visible fistula, no evidence of the meconium in the female. In such cases, you perform the cross-table Brunner radiograph. If the rectal area very close to the skin, the diagnosis may be whether narrow perineal fistula, not sending any meconium, or no fistula at all, which is very common with a Down syndrome patient. If the baby is stable, you can perform primary operation. If the baby is unstable, you can perform colostomy. So this is the algorithm for the clinical management of the female newborn with anorectal malformation. Also, no visible anus. The first 24 hours will be used for the searching for associated anomalies, and re-evaluation may disclose or show the perineal fistula, vestibular fistula. You have to perform anoplasty or dilatation or colostomy depending on associated conditions, stability of your baby. Single orifice, or what's called cloacal malformation. In such cases, you need to perform colostomy, hydrocolpus drainage if present. If there is no visible fistula, you will need to perform the cross-table X-ray, colostomy if the gas above the coccyx or unstable baby, severe associated anomalies, anoplasty if the gas below the coccyx, stable baby, no associated anomalies. Very important algorithm when dealing with a baby with female newborn with anorectal malformation. It's very important to follow a structured algorithm when dealing with male or female with anorectal malformation. The principles of the surgical repair in the female regarding rectoperineal fistula will be the same as the male newborn, and the rectum is not usually attached to the vagina, and the chance of the vaginal injury is very low. Regarding the rectovestibular, this is a complex, frequently underestimated. The complexity of this disorder underestimated. We need to perform multiple sutures and perform incision, which may be shorter than the male rectourethral fistula. Once the sphincteric mechanism is divided, the rectal will identified by the whitish appearance as we discuss in the male anorectal malformation. Most cases of these may get infected. Most cases of these may not be correctly performed. So it's a matter of the debate. These cases need a well-trained pediatric surgeon. As we see, the separation of the rectum from the vagina is very important. It's a challenge for the pediatric surgeon to create out two walls out of one between the vagina and this is the rectum and this is the vagina. This creation is very important, not to injure the vagina in such cases, to create out two wall out of one. This is the job of the pediatric surgeon, and this needs meticulous and fine dissection between the rectum and the vagina. Regarding the cloacal repair, the pediatric surgeon must know that the goal of the operation is to separate the rectum from the vagina and place it within the sphincteric mechanism. This is number one. Number two, the urethra and the vagina need to mobilize so that each has a separate orifice in the perineum like normal condition. The operation can be done once the baby demonstrated weight gain after colostomy opening. This is very important. The pediatric surgeon must know that there are two groups of the patient that must recognize well preoperatively. First is a child with common channel shorter than 3 cm, compromise the majority, treated with PASARB for the rectum and total urogenital sinus mobilizations for the urethra and the vagina, usually avoid laparotomy. This child or this female baby. On the other hand, long common channel more than 3 cm may reach up to 5 or 6 or 8. This is the most severe side of the spectrum. Laparotomy often needed. Vagina must be separated from the common channels. Sometimes need vaginal replacement. Sometimes need referral to specialized center. We can speak very rapidly about the principles of the surgical repair. For the cloaca with a common channel less than 3 cm, this is treated by the PASARB as we discussed and total urogenital mobilization. The PASARB incisions as we described before from the lower sacrum to the single perineal orifice, and after dividing the sphincteric in the midline, and you will see that first structures will be the rectum. The rectum posterior wall is opened and the incision will extend to include the common channel. And you aim to separate the rectum or to pull the rectum, and then you need to perform sinus, total urogenital sinus, moving the bladder and the vagina as one single unit after performing PASARB for the rectum. As we see, this is some operative image for the total urogenital sinus mobilizations. We take bringing both the vagina and the urethra to the perineum as a single unit, making multiple traction sutures on the edge of the vagina and the common channels, also other sutures on the proximal, about 5 mm proximal to the clitoris. Dissection will continue from the lateral and the anterior, also separating or cutting the suspensory ligament at the upper edge of the pubis to gain more or additional mobilization. The complete mobilization will end with that the vagina, introitus, and the urethral meatus can be anastomosed to the perineum and moved as a single unit after performing PASARB for the rectum. So this is composed of two elements, PASARB for the rectum and complete urogenital sinus mobilization, total urogenital sinus mobilization, in case we have short common channel, not more than 3 cm. So we can move the urethra and the vagina as a one unit and pulling them down to the perineum, so there is no long distance. The technique will end with 3 normal opening, the rectum placed within the sphincteric mechanism, and the urethra and the vagina technique preserves the excellent blood supply and place the urethra in a visible location so castration, if needed, can be performed. This type of the neonate can eat on the same day because the neonate usually have a colostomy. The pain usually easily controlled and discharged usually within 48 hours after surgery. Urinary catheter is left from 14 to 21 days. This is the simplest or the benign part of the spectrum of cloacal malformation with a common channel less than 3 cm. On the other side, if the pediatric surgeon faces a cloacal malformation with a common channel more than 3 cm, this is significant technically challenge. Entire lower body of the baby need to be prepared because the surgeon will need laparotomy after initial exploration through the posterior sagittal approach. The rectum is separated first, and depending on where is the vagina. If the vagina is low and we have a urethral length more than 1.5 cm, we can perform a total urogenital sinus mobilization. However, if the urethra is very short, the vagina must be separated from the common channel, making this common channel at the urethra. This is very important. The vagina may be, this problem is related to the vagina in a case of long common channel. Vagina may be single vagina of normal size. In such cases, the vagina is brought to the perineum and the introitus constructed after posterior urethra has been repaired. And this is lucky surgeon. Number 2, the vagina may be short vagina, very high, need to be augmented. Number 3, there is maybe totally absent vagina, need to be replaced or reconstructed from the bowel segment. Number 4, we may have 2 hemivaginas with a very high vagina. This is require maneuver to bridge the gap called vaginal switch, and we will discuss it. So the vaginal situation in a case of long common channel may be 4 options. Maybe single vagina, the surgeon may find single vagina of normal size. In that case, the vagina is brought to the perineum and the introitus is constructed. Very straightforward. Maybe short vagina, totally absent, maybe 2 hemivaginas. We'll start with number 4, vaginal switch maneuver. In such patient with cloacal disease, the patient born with, as we see, bilateral hydrocolpus. These 2 hemivaginas, 1 and 2, filled with urine and mucus, forming bilateral hydrocolpus, and there is 2 hemivaginas very high in the abdomen, away from the perineum, and separated with 2 hemiuteri. This is 1 hemiuteri, and this is 1 hemiuteri. This is the tube and the ovary on the right and the left side. So this situation is the 4 situations. You may find 2 hemivaginas, bilateral hydrocolpus, and this vagina already, both hemivaginas are very high in the abdomen. In such cases, we will perform what's called vaginal switch, which means that the blood supply of one vagina and one uterus is divided. We divide the blood supply here and sacrifice this one uteri, and this vagina will be supplied from the opposite side. Also, vaginal septum is divided like this, and then the vagina will be switched down to reach the perineum. This is a new single vagina reaching the perineum. So the blood supply of the one vagina is sacrificed. The collateral vessels from the opposite vagina will supply both. This is the vessels. The vaginal septum between both resected, creating single large one. The cut end of the vagina is then turned down or switched down to reach the perineum. This is vaginal switch maneuver, rarely used. Nowadays, it is described when you find 2 hemivaginas, bilateral hydrocolpus, with a very high vagina, so that the longitudinal distance between the 2 hemivaginas are very high. Longitudinal distance more than the vertical distance you need to pull down the vagina. So you decide to sacrifice one side of the blood supply and then close this end and rotate down to what's called vaginal switch maneuver. On the other side, if the pediatric surgeon finds short vagina or totally absent vagina, this may be reconstructed or replaced from the bowel segment. We may have intestinal choice to use part of the rectum, part of the colon, or part of the small bowel to replace the missing vagina. The rectum, when the patient especially has a megarectum, it is divided longitudinally, preserving the blood supply to both segments, and this segment will perform the new vagina, and this will perform the rectum, the usual rectum. The rectal blood supply will be provided transmurally for this part, no problem, and this new vagina, we preserve its blood supply from the arcades and the mesenteric vessels. This is rectum. This is the first choice if the patient have a megarectum, allowing us to divide this rectum between longitudinally or transversely between the natural rectum and the new vagina. The second choice is the colon, especially the left colon and the site of the proximal colostomy due to more mobile part with long mesentery. And if we have a little cuff of the vagina, the upper part of the colon is sutured to the upper vaginal cuff to complete the vagina to reach the distance. If there is no vagina at all, no uterus, the new vagina created will only act for intercourse, not more. So the colon can be used to augment or replace the missing vagina. This is the colon. We can take the left colon, preserving its blood supply, the site of the colostomy, the most mobile with the long mesentery. So this is the second choice after the rectum. If the rectum is not available, can choose the colon. Number 3 is the small bowel. If the colon segment not available, most mobile part of the small bowel can be used for the vaginal replacement. We start to select the ileum about 15 cm proximal to the ileocecal and cut this and pull this segment with its blood supply to complete the distance. This is the natural vagina and this is the tubes. So we use this small bowel to replace the missing part of the vagina. It's very important for the pediatric surgeon to take a decision making regarding the condition of the vagina. Is the vagina is a normal one? Is vagina is a short one? Totally absent vagina? 2 hemivaginas very high in the abdomen with bilateral hydrocolpus. The surgeon may perform vaginal switch maneuver. Regarding the post-operative management for both male and female anorectal malformation, there is important items that must be we must stress on them. Number 1, generally the anorectal malformation patient have a smooth post-operative course. The pain is rare complaint, except after laparotomy. Most patients discharge 2 days after BASARB, 3 to 4 days if laparoscopy or laparotomy. Anal structures develop when the blood supply to the distal rectum is insufficient or when anoplasty was performed under tension. Regarding urinary catheter, after the cloacal repair, 14 to 21 remain urinary catheter until the perineum is no longer swollen and the infant can be recatheterized if needed. The complex malformations of the cloacal anomalies may need suprapubic tube or vesicostomy and may be stemmed. Regarding the rectourethral fistula in the male, we left the catheter for 7 days. If the catheter dislodged, however, the baby often void without difficulty, and we don't require catheter replacement. Regarding anal dilatation, usually started 2 weeks after the repair. Once the desired size is reached, colostomy can be closed. The routine daily dilatation is not required, usually in all patients, and regular checking by the pediatric surgeon to ensure that the structure is not devolving is very important. The size of the dilator will be related to the age, 1 to 4 months, 4 to 12. This is the size or numbers of the Heger dilators required. So daily dilatation not usually required. The decision will be related to the pediatric surgeon checking and follow up for the baby. After colostomy closure, the baby may have multiple bowel movement with perineal rash, and constipating diet will be helpful in this situation. After several weeks, the number of the bowel movement decrease, and the most infant may develop constipation and need laxative. And after 1 to 3 months, most of the infant develop regular bowel habits management. This is related to the bowel movement after colostomy closures. The functional bowel movement is very important to understand that we have a good prognosis for the bowel control and bowel movement, and we have a poor prognosis. The baby with good prognosis, usually patient with 1 to 3 well-formed bowel movement per day and remain clean in between, show evidence of filling or pushing during the bowel movement. On the other hand, if the patient present with multiple bowel movement passes stool constantly without showing any signs of sensation or pushing, in such case, we may suspect a poor prognosis, and this patient may require bowel management. On the good prognosis side, the patient can be toilet trained and will be near or normal. Regarding voiding, about 1 in 5 patients with cloacal malformation with a common channel less than 3 cm require clean intermittent castration to empty their bladder. Most patients with a common channel more than 3 cm require CIC, clean intermittent castration. Postoperatively, infant observed for spontaneous voiding, kidney and bladder ultrasound, assess emptying and performed every 2 to 3 weeks after caster removal and repeated every several months to follow that there is good emptying, there is no residual urine, which may lead to urinary tract infection, ascending infection of the kidney. If the patient cannot pass urine or doesn't empty your bladder well, the parent must learn how to perform clean intermittent castration, generally voiding, even with the assistant or control, and the absence of the urinary tract infection is reassuring, but doesn't guarantee adequate bladder emptying. Therefore, these babies need to be followed very closely to avoid progression to chronic kidney disease. So it's very important to follow the children after rebirth of anorectal malformation, especially the cloacal malformation, to comment on the voiding, whether the baby able to void spontaneously, need to be assisted, whether you need to learn the parent to perform clean intermittent castration, perform an ultrasound, so if there is no residual urine, you must follow adequate bladder emptying to avoid progressions of urinary tract infections and chronic kidney disease. Most babies with the cloacal malformations have a flaccid, smooth, and large bladder that doesn't empty completely. However, surprisingly, they have a competent bladder neck, making them ideal for clean intermittent castration, which keep them completely dry. So this is a cloacal malformation. The exceptions to this rule is when we have a very long common channel and 2 hemivaginas that attach it to the bladder neck, which were separated during the rebirth, and there may result in a bladder neck damage if the total urogenital mobilization done with a very short urethra, the patient will leak, and the baby born with separated pubic bones, what's called covered extrophy, with a congenital absence of the bladder neck. So this is the exception of the rule, that most cloacal malformation patients have a large flaccid bladder, competent bladder neck. So they will be candidate, ideal for clean intermittent castration, except with a very long common channel hemivaginas and operation trying to separate the bladder, to separate the vagina from the bladder, you may injure the bladder neck or cause bladder neck damage. This baby will have lost the competent bladder neck. Also, if total urogenital sinus mobilization is done on the very short urethra. And lastly, if the child born with a condition called covered extrophy with separated pubic bone and congenital absence of the bladder neck. All these exceptions will require a complex bladder neck work and bladder neck closure with Mitrofanov reconstructions to achieve dryness. Now we will speak about the most important and the last one is the functional outcome after anorectal malformation rebirth. The most patient after successful repair of the anorectal malformation still continue to suffer from some degree of defecation problems. It is important to understand that fecal continence normally depend on the presence of the voluntary muscles, the anorectal sensation, the bowel motility, and the rectal reservoir. 4 items controlling the fecal continence. Let's to concentrate in this point. Number 1, voluntary muscles. We mean by the voluntary muscle, the levator muscle, the muscle complex, and the parasagittal fibers. All these called the voluntary muscles. Normally, they used only for a brief period when the fecal mass pushed by the peristaltic contractions of the rectosigmoid, pushing the fecal mass to the upper part of the anorectal area in the few minutes before defecations. These voluntary muscles are used here, whether to relax and allow the rectal mass, fecal mass to pass, or contract and pushing back this fecal mass to the rectosigmoid and holding them if the surrounding circumstances not appropriate for defecation. So normally these voluntary muscles will present and their function will be related to control the defecation time. The fecal mass will be pushed by the contraction of the rectosigmoid, reaching the upper anorectal area and the upper rectum. And these muscles will control according to the person what happened in the surrounding circumstances. If the person decides to go for defecation, they will relax. If the circumstances are inappropriate, they will contract and pushing them this fecal mass back. At the time of the defecations, you will relax. Yes, what happened in anorectal malformation? In patients with anorectal malformation, there will be abnormal voluntary muscles, or these babies may have some degree of hypodevelopment. So the continence related to this point will be affected, as this voluntary muscle may be abnormal or may be hypodeveloped. Number 2, for continence is the anorectal sensation. In order to use these voluntary muscles, what we says as a mechanism for control of the voluntary muscles, you need an intact sensation, intact sensory mechanism in the anal canal. This sensory mechanism is lacking, not present in anorectal malformation, as most patients with anorectal malformation born without anal canal, except rectal atresia and stenosis. Therefore, the anorectal sensation doesn't exist or is rudimentary. So these the second items may affect the continence ability in this type of children. The anorectal sensation is affected. However, there is still some types of the distension. There's some type of sensation that present in these children. What's called a rectal distension. Rectal distensions, if the rectum located well within the sphincteric complex, this rectal distension will make what is called proprioception. Proprioception type of sensation that result as the result of a stretching of the muscles. So we can imagine that if there is a liquid or soft stool, the patient with anorectal malformation may not feel any sensation about the passing of the content and will be incontinent. However, if there is a rectal distension, and this rectal distension will make a proprioception, so the patient will have some sort of continence. So rectal distension can be felt by the many patients if the rectum located accurately within the muscle complex. This is called proprioception as a result of stretching of the voluntary muscle. Therefore, liquid or soft stool may not be felt by the patient with anorectal malformation because the rectum is not distended. So to achieve some form of sensation and the bowel control, the patient must be able to form solid stool or help it to form solid stool. So this solid stool will make a proprioception. The bowel motility. Normally, the rectosigmoid remain quiet for a variable time, depending on the individual defecation habits. During that time, the anorectal sensation and the voluntary muscles are unnecessary, because the stool, if it is solid, will remain in the rectosigmoid area. Normal individual can voluntarily contract or relax these striated muscles, allowing the rectal content to migrate down through the sensitive area of the anal canal with information regarding consistency and the quality of the stool. The main factor that initiate the emptying of the rectosigmoid is involuntary peristaltic contractions, sometimes helped by Valsalva maneuver. Most patients with anorectal malformation have a disturbance of the bowel motility mechanism. Therefore, their colon move very slowly, abnormal or hypodeveloped muscles. So these three items, the first three items regarding the voluntary muscle, regarding the sensations, regarding the bowel motility, it seems all to be affected in the anorectal malformation patient. The fourth one is the presence of the rectal reservoir. Patient after BASARB, in which the most distal part of the bowel was preserved, often have an over-efficient bowel reservoir. This is called megarectum after BASARB, dilated lower part, and called megarectum. The clinical manifestation of this megarectum is constipation, more severe with the lower anorectal malformation disorders. The dilated rectosigmoids has a normal ganglia but behave like a hypomotility one. Then after constipation, there is maybe overflow fecal incontinence. These patients have a good potential for the bowel control. Need treatment with appropriate dose of stimulant laxative rather than stool softening. So in the patient with low defect, in which posterior sagittal anorectoplasty was used for the treatment, usually the distal part of the bowel is preserved. This distal part is called rectal reservoir, and it will be dilated. This will be beneficial for these babies as they may lead to constipation. Constipations, this dilated rectal reservoir will have a normal ganglia, unlike Hirschsprung disease, but behave like hypomotility disorders. And on and off, there is maybe overflow fecal incontinence. So these babies have a good potential for the bowel control and need some form of treatment with a stimulant laxative. On the other hand, if the patient treated with older technique in which is a distal part of the bowel resected, abdominoperineal Boltzrow, they have lost the rectal reservoir. This baby have a poor potential for the bowel control and need mechanical cleaning with a daily enema. So the presence of this rectal reservoir may be beneficial for the babies with low anorectal defects. So at the early of the lecture or presentation, we discussed that the babies with a low anorectal may present with severe constipation. This is explained by the presence of the rectal reservoir. This dilated megarectum have a normal ganglia but behave like hypomotile. Depending on the amount of the colon resected, the patient may have loose stool. In such cases, medical management, constipating diet, medication to slow down the colonic motility with a small mechanical flush may be indicated or may be required. So regarding this point, functional outcome of the fecal continence, 4 items is very important. The voluntary muscles, which is abnormal or hypodeveloped in anorectal malformation patient, the sensation not present, as the anal canal not present in most of the cases, and the recto and the bowel motility, which is also abnormal, and finally the presence of the or absence of the rectal reservoir. There is some postoperative complication, maybe wound infections. It's very straightforward, caking the skin or subcutaneous tissue sometimes, pus without functional sequelae. Also anal strictures, if there is anoplasty under tensions or without adequate blood supply. The constipation and the soiling may be very common functional problem. It's vitally important to treat the constipation after colostomy closure to avoid later problems with dilatation and severe constipation. Rectal prolapse may be common in higher anorectal malformations, poor sphincter, and it will be worsened by the postoperative constipation. transient femoral nerve palsy due to excessive pressure on the groin while in the prone position and avoided by adequate cushioning under the pressure areas. The urethrovaginal fistula after cloacal malformation repair, most problematic complication, but avoidable when the total urogenital mobilization is used. It must be that 90% rotation of the vagina and coverage of the posterior urethra with a biomatrix and ischiorectal fat pad when the vaginal mobilization and separation from the new urethra is needed to decrease the incidence of this fistula. So the urethrovaginal fistula may develop after some cases of the cloacal repair. In some cases, you need to strengthen the posterior wall of the vagina using the biomatrix or ischiorectal fat band. Vaginal strictures may be from excessive tensions or deficient blood supply. Urinary injuries, failure to obtain a good distal colostogram appears to be the major cause. Neurogenic bladders in the male in the presence of the good sacrum and spine, most likely due to dissection of the rectum in a wrong place. This is some complications. In conclusion, the proper use of the therapeutic and prognostic-oriented classification of anorectal malformation is required. The most common anorectal malformation is the rectovestibular fistula in the female, rectourethral fistula in male. Half of the patients with anorectal malformation without fistula have a Down syndrome. Laparoscopic or abdominal approach is best for the bladder neck or the high prostatic fistula. Lower prostatic and bulbar best approach through Bassar. In the male, it's very important to carefully dissect the common wall between the anterior rectal wall and the posterior urethra. In the female, it's very important to create two walls out of one between the rectum and the vagina. The preoperative high-pressure distal colostogram is very essential for planning the proper surgical plan. A patient with rectal atresia and stenosis with a normal appearing anal canal and dentate line, the workup should specifically evaluate for the presence of the presacral mass, which is very essential. In a cloacal malformations, we may have a short channel less than 3 cm or long common channels more than 3 cm, and the urethral length is very essential for making the decision. We may need vaginal augmentations. The divided proximal colostomy with separate stoma is the best for anorectal malformations. The newborn requires up to 24 hours for the distal colonic pressure to define the fistula. That time used for evaluation of associated anomalies. So our topics today is very essential for the pediatric surgeon. We speak about anorectal malformations. It's very important that the first 24 hours of life of the baby of anorectal malformation is extremely important. The decision taking in the terms of the management of the baby may have significant consequences, really positive or negative, on the baby life. We concentrate or try to rule out the presence of the associated anomalies, which may be dangerous to the baby life. The presence of the cardiac anomalies, the presence of the esophageal atresia is very important. It's very important to perform an ultrasound for the abdomen. It's very essential. Also, we should try to study the characteristic of the baby sacrum, which is very important to diagnose deficient sacrum. This will have an implications on the future continence ability of the child, which is very important. Also, the presence of the tesseract cord, which can be diagnosed with an ultrasound during the first 3 months, which is very essential to perform spinal ultrasound. We must remember that parents waiting for us to tell them what's the futures of the baby in the terms of the bowel and urinary control. It's very important to answer these questions. We should make a decision about whether the baby need a full repair or need opening a colostomy. If you decide to open a colostomy, you must perform technically correct colostomy in the descending colon completely diverting colostomy with separations of the bossostoma, leaving enough distal bowel for subsequent bowel through. This is very important. Regarding the cloacal malformation, normally the female present with the three opening for the anal, for the vagina, and the urethra. In such cases, all three structures creating the common channel or common chamber, and the prognosis will depend on the length of this common channel. On the benign spectrum, we may have a less common channel, less than 3 cm. On the other side, lung common channels, more complex, may need vaginal mobilization, vaginal replacement. We may find hydrocolbus, pyocolbus, or hydronephrosis. Anorectal malformations is a common congenital anomaly. Very important to understand the new terminology and the classification. The classification of the high and the low and the intermediate are not used nowadays. The new classification will be therapeutic and prognostic, related to male and female, related to the presence of the rectoperineal and rectourethral or no fistula or rectal stenosis in male, related to rectoperineal, rectovestibular, cloacal malformations in the female. The principles of the surgical rebirth are very important for the pediatric surgeon. You may need to refer to some operative details for more informations. Regarding the functional outcome, the main concern for the continence, it's very important to evaluate the sacrum of the baby. You must know that the continence depends normally on the presence of the 4 items, the voluntary muscles, the presence of the sensations, the motility, and finally, the presence or absence of the rectal reservoir. Thank you very much for your attention. I think it's a very important subject for all pediatric surgeon and pediatrician. And see you next in next subject of pediatric surgery made easy. Thank you very much.